That's a little ominous to start a deep dive with.
It is, but hear me out. It fits perfectly. We are looking at Chapter 46 of our medical text today, specifically focusing on sexually transmitted diseases.
Right.
And the thing that struck me, the thing that actually kind of terrified me, is how incredibly quiet these biological machines are. We tend to think of infection as this loud event. You get a fever, you cough, you feel terrible, you lie down.
Right. The body pulls the fire alarm.
Exactly.
Eh,
But looking at the Centers for Disease Control data in this chapter, looking at the epidemiology, these pathogens are ninjas. They are designed to be invisible. They infiltrate, they hide, and they spread, often without the host having a clue.
That is the perfect framing. I mean, if you look at this from an evolutionary biology perspective, which the text encourages us to do, a loud disease is actually a failure.
A failure. How so?
Well, if a virus kills you or knocks you flat in bed, within hours, you stop moving, you stop
You
interacting,
definitely stop having sex.
and the pathogen dies with you. Or at least it stops traveling.
Okay.
Precisely. But the organisms we are discussing today, the bacteria, the viruses, the protozoa, they have perfected the art of keeping the host healthy enough, or at least seemingly healthy enough, to keep the chain of transmission going.
It's a masterclass in survival strategy.
It really is.
So that is our mission today. We aren't just reading a list of symptoms that make people cringe. We're unpacking a biological war manual. We're going to look at the classic venereal diseases, but we're going to peel back the layers to understand the modern mechanics of how these things operate, how they hide, and frankly, how they wreck the human body if we aren't paying attention.
And the scope is so much wider than people realize.
Yeah, let's set the stage there. I think when people hear STD, they have a mental checklist. You know, gonorrhea, syphilis,
Maybe herpes.
maybe herpes, but the source material lists a veritable zoo of pathogens.
It does. The text breaks it down into categories that go way beyond just bacteria. We're dealing with viruses like HIV and herpes, obviously. But then you have fungi, you have protozoa,
Wow.
you even have ectoparasites, literal bugs that live on the skin.
It's a full-spectrum biological assault.
It is. The chapter highlights the classic venereal diseases: gonorrhea, syphilis, chancroid, lymphogranuloma venereum, and granuloma inguinale.
Those are the historic heavy hitters.
They are. But the modern definition of what can be sexually transmitted is broad. It's essentially any pathogen that exploits intimate contact as a bridge between hosts.
And as we dive into these, I want to stick to that theme of silence you mentioned, because as I was reading about the first big player on our list, gonorrhea, that was the standout statistic, the gender divide in how loud the disease is.
It is one of the most unfair biological quirks in medicine. We are talking about Neisseria gonorrhoeae.
The clap, as it's historically known.
Historically, yes. The text describes it as a gram-negative diplococcus.
Okay, let's pause there, deep dive style. What does gram-negative diplococcus actually tell us?
So diplococcus means the bacteria travel in pairs. If you were to look under a microscope, they look like two little coffee beans side by side.
Okay.
And gram-negative refers to the structure of their cell wall. It's a specific type of armor that makes them resistant to certain antibiotics and very good at evading the immune system.
And they are specialists. The text says humans are the only known host.
That is correct. You won't find gonorrhea in your dog or your cat. This parasite has co-evolved specifically to live inside human beings. It knows our anatomy better than we do.
And it is busy. The source estimates up to 600,000 infections per year in the U.S. alone.
Yeah, it's very prevalent.
But let's get back to that gender divide. If a man catches gonorrhea, he knows it, right?
Typically, yes. The incubation period is short 1 to 14 days. The text describes the classic presentation in men as dysuria and urinary frequency.
Which is medical speak for it hurts to pee.
Intense pain. And then there is the discharge. The text calls it a purulent urethral discharge.
So it's obvious.
It's visible, it's uncomfortable, and it's alarming. Men tend to seek treatment quickly because their body is, screaming at them.
But for women, the text paints a completely different picture.
It's dangerously subtle. The text notes that women are often asymptomatic or minimally symptomatic.
Minimally symptomatic is such a trap. It sounds like maybe you just feel a little off, little irritation.
Exactly. Maybe you think it's a mild yeast infection or just a fluctuation in your cycle. You brush it off.
You ignore it.
And because you brush it off, you don't get treated. And this is where the silent nature becomes destructive. The bacteria doesn't just sit there.
It goes on a march.
It ascends. If untreated, Neisseria gonorrhoeae invades the upper reproductive tract. This is the mechanism behind PID, pelvic inflammatory disease.
A text says this happens in about 15% of untreated women. And PID isn't just an infection, it's a scarring event.
That's the key. It causes inflammation in the fallopian tubes. When that inflammation heals, it leaves scar tissue.
Oh.
That scar tissue can block the tubes completely, causing infertility. Or even worse, it can partially block them.
Which leads to ectopic pregnancy.
Right. The egg gets fertilized, but can't make it past the scar tissue to the uterus. It implants in the tube.
And that's a life-threatening emergency right there.
A huge one. So you have a situation where silent infection today leads to a surgical emergency or infertility 10 years down the road.
It's a slow-motion car crash. And the text mentions it doesn't even stop at the reproductive organs. There's this terrifying section on disseminated disease.
DGI, disseminated gonococcal infection. This occurs in about 0.5% to 3% of patients. The bacteria figure out how to enter the bloodstream.
So now you have gonorrhea in your blood.
It travels. It likes joints and skin. The text lists the symptoms: tender necrotic skin lesions.
So dying tissue spots on the skin.
Yeah. And tendinosynovitis, which is inflammation of the tendon sheath.
And monoarticular arthritis.
Which means one single joint becomes incredibly swollen and painful. A knee, a wrist.
Wow.
Imagine going to the doctor because your knee is the size of a grapefruit and finding out the cause is an STD you didn't even know you had.
That's wild. It really highlights why this strategy of the bacteria is so effective. It exploits our assumptions about where these diseases live.
Absolutely.
There is one more victim profile for gonorrhea that we have to mention because the text is very specific about it. Infants.
This is a huge public health victory, actually. We are talking about ophthalmia neonatorum.
Eye infection in newborns.
Correct. If a mother has an untreated infection in the birth canal, the infant is exposed during delivery. The bacteria can infect the conjunctiva of the eye. Before modern medicine, this was a leading cause of blindness.
And the text mentions a very specific protocol that happens basically the second a baby is born.
It's standard of care. The CDC recommends erythromycin 0.5% ophthalmic ointment. It is applied to the infant's eyes immediately postpartum.
So if you've ever seen a brand new baby and they have that shiny, greasy look around their eyes.
That is the erythromycin. It's a chemical barrier. It kills the bacteria on contact and prevents blindness.
It's incredible.
It's a simple intervention that has saved millions of people from losing their sight.
Wow. Now, you can't really talk about gonorrhea without talking about its partner in crime. They seem to be the Thelma and Louise of the bacterial world.
Chlamydia trachomatis.
The text says this is believed to be the most common STD in the U.S.
It is.
So gonorrhea is bad, but chlamydia is the king of quantity.
It is highly prevalent. And biologically, chlamydia is even stranger than gonorrhea. The text classifies it as an obligate intracellular parasite.
Let's decode that. Obligate intracellular.
It means it literally cannot survive outside of a host cell.
Oh.
Bacteria like E. coli or staph can live on surfaces or in fluid. Chlamydia cannot. It has to penetrate the wall of your cells and live inside the cytoplasm to reproduce.
So it's a hijacker.
It steals the cell's energy. It's ATP. It's almost vampire-like in that sense.
It blurs the line between a bacteria and a virus.
It really does. And if gonorrhea was quiet in women, chlamydia is a ghost. It is the true stealth pathogen.
The stats in the text are staggering. In men who usually catch gonorrhea pretty fast, more than 50% of chlamydia infections are asymptomatic.
Right, so half the men walking around with it have no idea.
And for women, it's even higher. More than 66% of cervical infections are asymptomatic. 2/3.
Which explains why it is the most common STD. If 2/3 of the carriers feel fine, they don't stop having sex, they don't go to the doctor, they just spread it.
It is perfectly evolved for transmission.
Perfectly.
And the risks are similar to gonorrhea, PID, infertility.
Very similar. It causes the same scarring and upper tract damage. And it also poses a massive risk to infants. The text notes that nearly 2/3 of infants exposed during birth will acquire the infection.
And not just in the eyes.
No. The text lists the nasopharynx, rectum, and vagina. It can even cause chlamydial pneumonitis, a lung infection in a newborn.
Jeez. Because these two bacteria, gonorrhea and chlamydia, are so often found together, that actually changes how doctors treat them, right? The text talks about co-infection.
This is a critical practical point. The text states that coexisting chlamydial infection is found in up to 50% of women and 20% of men who have gonorrhea.
That's a coin flip for women. If you test positive for gonorrhea, there is a 50% chance you also have chlamydia.
Exactly. And because testing used to be slower, and because the risk is so high, the CDC treatment guidelines are built around the assumption that you have both.
Shoot first, ask questions later.
In a way, yeah. We call it concomitant treatment.
Yeah.
So for the gonorrhea, the recommendation is parenteral ceftriaxone.
That's the shot.
Yes, an intramuscular injection. It's a cephalosporin antibiotic. But you don't stop there. The text says you add doxycycline or the zithromycin to the regimen.
And those are specifically for the chlamydia.
Correct. Ceftriaxone is great for gonorrhea, but not effective for chlamydia. Doxycycline wipes out the chlamydia, so you give both. You cover your bases.
It makes sense.
You don't want to cure the gonorrhea and leave the silent chlamydia eating away at the patient's fertility.
It's a scorched earth policy. I like it.
It's necessary.
Okay, so we've covered the bacterial heavyweights. Now I want to pivot. We need to talk about the great imitator. This part of the chapter felt less like a medical text and more like a gothic horror novel.
Oh, yeah.
We're talking about syphilis.
Syphilis is.
Yeah.
It's in a league of its own. The agent is Treponema pallidum.
Spiro shit.
Yes, which describes its shape. It's a corkscrew. If you watch it under a dark field microscope, it actually spirals. It drills itself into tissue.
That is a visceral image. Drills into tissue.
It's accurate. And unlike the other bacteria we discussed, syphilis plays the long game. The text breaks it down into a staging system that spans decades.
A narrative arc of infection.
Exactly.
Let's walk through the story. Act 1. Primary syphilis.
The infection starts with a specific lesion called a chancre. This appears at the site where the bacteria drilled in.
Describe the chancre, because the text makes a big deal about differentiating it from other sores.
It is a single, indurated lesion. Indurated means hard or firm to the touch. And the most important feature, it is painless.
That seems like a fatal flaw in our body's defense system. Pain is the signal that says, fix me.
Right.
If it's painless, you might ignore it.
Exactly. And here is the magic trick of syphilis. The text says the chancre persists for 1 to 8 weeks and then spontaneously disappears.
Even if you do nothing.
Even without a single milligram of antibiotic, the sore heals.
So the patient thinks, whew, bullet dodged. I'm fine.
But they aren't fine. The disappearance of the sore just means the bacteria has finished its local invasion and has moved deeper.
Oh, man.
It has entered the bloodstream and the lymphatic system. It is spreading to every corner of the body.
Which brings us to Act 2, secondary syphilis.
This happens about 2 to 8 weeks after the chancre heals. Now, the disease is systemic. The bacteria are everywhere.
And the symptoms explode.
Yes. The text lists mucocutaneous eruptions. Essentially a rash, but it's a specific kind of rash. It often appears on the palms of the hands and the soles of the feet.
That's a classic giveaway.
It is. And along with the rash, you get flu-like symptoms. Fever, malaise, swollen lymph nodes, lymphadenopathy. Yeah. The body is reacting to a massive bacterial load.
But then the magic trick happens again.
It does. The finds resolve in 4 to 10 weeks. The rash fades. The fever breaks. The patient feels normal again.
And this is the most terrifying part of the text for me, the latent phase.
Science. Absolute science. You'd have a positive serology, meaning a blood test would scream that you are infected, but absolutely no physical evidence of disease.
So where are they?
The corkscrew bacteria go dormant in the tissues.
And how long can this last?
Years. Decades.
Yeah.
The text mentions early latent and late latent. You can live a normal life, completely unaware that this colony is waiting inside you.
Until Act 3, tertiary syphilis.
The tragic finale. This develops in about 30% of untreated patients. And the timeline is staggering, 10 to 30 years after that first painless sore.
So you get infected in your 20s, and this hits you in your 50s.
Precisely. And the damage is catastrophic. The text describes gummatous lesions. These are soft, tumor-like balls of inflammation that can grow on your skin, in your liver, or on your bones. They just eat away at the tissue.
And it attacks the heart.
Cardiovascular syphilis. It causes inflammation of the aorta, the main artery of the body. It can weaken the wall until it balloons out in aneurysm and bursts.
And finally, the brain. Neurosyphilis.
Now, the text makes an important distinction here. Neural syphilis can actually happen at any stage.
Well, really?
Yeah. Even in the primary or secondary stage, the bacteria can invade the central nervous system. The text says 40% of patients have CNS involvement early on.
But the late-stage neurosyphilis is the one we associate with madness.
Yes. Meningitis, dementia, general paresis. It literally destroys the brain parenchyma. Before penicillin, our psychiatric asylums were filled with people suffering from tertiary syphilis.
Wow.
They lost their memory, their personality, their motor control.
Taves dorsalis is listed. That's the loss of coordination, right?
Yes, degeneration of the spinal cord nerves.
Yeah.
They would walk with a distinctive slapping gait because they couldn't feel where their feet were hitting the ground.
It's horrifying. So if the symptoms keep disappearing, how do we actually catch this thing before it eats our brain?
Diagnosis is tricky. You can't just culture Treponema pallidum in a petri dish like you can with staph. It won't grow.
It's too picky.
It's too dependent on the host. So if you have a chancre, we use dark field microscopy. We look for the actual corkscrew shape moving in the fluid. But usually we rely on blood tests.
The VDRL and RPR.
Right, those are screening tests. And if it's positive, we have the silver bullet.
Penicillin G.
It is still the absolute gold standard. Despite all the antibiotic resistance we see in other bugs, syphilis has never learned to outsmart penicillin.
However, there is a warning in the text about treating syphilis, a reaction that sounds almost as bad as the disease for a few hours, the Jerisch-Herxheimer reaction.
This is fascinating physiology.
Hmm.
Imagine a patient with secondary syphilis. They are loaded with spirochetes, billions of them in their blood.
Okay.
You give them a shot of penicillin.
The bacteria die.
They die en masse,
What?
instantly. And as they burst open, they release all their endotoxins and lipoproteins into the bloodstream at the exact same moment.
It's a toxic shock.
Exactly. About 2 hours after the shot, the patient gets a sudden high fever, chills, rapid heart rate, muscle pain, and a pounding headache. It looks terrifying, like a severe allergic reaction.
But it's actually a sign of success.
Ideally, yes.
Yeah.
It means the drug just killed a massive amount of bacteria. It resolves on its own in 24 hours. But you have to warn the patient, or they will think you poisoned them.
You're going to feel like you're dying, but that means you're living. Medical paradoxes are the best.
They keep things interesting.
All right, let's shift gears. We've done the bacteria, now we enter the world of the forever infections, the viruses. And the big one here is herpes.
HSV, herpes simplex virus.
Now, most people know the rule of thumb. HSV-1 is the cold sore on your lip, HSV-2 is the genital one. Does the text hold that up?
Mostly, but with caveats.
Mhm.
The text says HSV-1 is usually oropharyngeal, and HSV-2 is usually genital. But biologically, they are very similar.
So they can cross over.
You can get HSV-1 on the genitals via oral sex, and vice versa. And the text says the primary infection, the first time you get it, can be indistinguishable clinically.
Right. A sore is a sore.
But the text points out a crucial difference regarding this future: recurrence. HSV-2 is much more likely to keep coming back in the genital region than HSV-1 is.
So HSV-1 doesn't like living down there quite as much.
Pretty much, yeah.
Let's talk about that first episode. The text describes it as pretty rough.
It is typically the worst outbreak a patient will ever have. You get multiple painful pustules that break open into ulcers. It can last 2 to 4 weeks. And because it's a virus, it goes systemic.
So flu-like symptoms.
Fever, headache, malaise. It feels like a bad flu accompanied by painful sores.
But then it heals, and this is where the viral strategy is totally different from the bacterial one. The bacteria we talked about, gonorrhea, syphilis, they can be cured. You take the antibiotic, they die, they are gone.
Correct.
But herpes moves in.
It enters a state of latency. The virus travels up the sensory nerve fibers from the skin all the way to the nerve root, the dorsal root ganglion near the spine, and it just sits there.
It hides.
It integrates its DNA into your nerve cells. It becomes part of you.
That is sci-fi levels of creepy. It hides in your own nervous system to avoid your immune system.
Exactly. The immune system cleans up the skin, but it doesn't attack your own nerve ganglia. So the virus is safe.
And then something wakes it up.
Stress, sunlight, illness, menstruation. The virus reactivates, travels back down that same nerve fiber to the skin, and starts replicating again. That is the recurrent infection.
But the text says these are usually milder.
Much milder. Healing takes about 7 days. But there's a warning sign: the prodrome.
The tingle.
About 50% of patients can feel it coming. A burning, itching, or tingling sensation at the site before any sore appears. This is the virus traveling down the nerve.
Now, there is a concept here that I think is the single most important thing for our listeners to understand about herpes. It's a term that kept popping up: viral shedding.
This is crucial for public health. There's a misconception that you are only contagious when you have a big, ugly sore.
I look clean, so I'm safe.
That is false. The text explicitly discusses asymptomatic shedding. The virus can reactivate and make its way to the skin surface without causing a visible lesion.
So you're contagious, but have no symptoms.
You are shedding microscopic viral particles. You look fine, you feel fine, but you are infectious.
That is the silent theme again.
It is. The text notes this shedding is most frequent in the first year after infection, but it can happen anytime.
So if we can't cure it, how do we manage it? The text mentions palliative care.
For the pain, saline baths, analgesics, just keeping the area clean.
Well, we have drugs, right? The VER drugs.
Acyclovir, valacyclovir, famciclovir. These are antivirals. They work by interfering with the virus's ability to replicate its DNA.
Do they kill the virus in the nerve root?
No. Nothing we have can reach the latent virus in the nerve. These drugs only stop the active replication, so they shorten the outbreak, they make it heal faster.
And for people who get outbreaks all the time, like every month, there is suppressive therapy.
Taking the medication every single day. The text gives a strong stat on this. It can reduce the frequency of recurrence by 70 to 80%.
That's significant. It turns a constant burden into a manageable annoyance.
Exactly.
Okay, moving on. We've done bacteria, we've done viruses. Now we have to talk about the animal.
The protozoan.
This one blew my mind a bit. Trichomoniasis. It's not a bacteria. It's not a virus. It's a tiny single-celled animal.
Trichomonas vaginalis.
Yeah.
It's a eukaryotic organism, much more complex than a bacteria. The text describes it very visually. Flagellated, motile, and pear-shaped.
Motile means it moves.
It swims. It has little whip-like tails called flagella. If you look at a sample under a microscope, you don't just see dots. You see these pear-shaped creatures swimming across the slide.
That is a horrifying image for a deep dive. Thank you for that.
It is biology in action, and it is very common, 3 to 5 million cases per year.
And again, we see this gender divide in symptoms similar to gonorrhea.
In a way,
Yeah.
men are usually asymptomatic carriers. The protozoa live in the urethra but don't cause much trouble. But for women, it produces a very specific, very unpleasant set of symptoms.
The discharge description in the text is vivid.
Malodorous, yellow-green, frothy.
Frothy.
A protozoa produce gas as a byproduct of their metabolism, which creates bubbles in the discharge, hence frothy.
And the text mentions the strawberry cervix.
Colpitus macularis.
Okay.
The cervix becomes so inflamed and covered in little red hemorrhages that it looks like the surface of a strawberry. It's a classic diagnostic sign.
So to diagnose it, they actually look for the little swimming guys.
Yes, a wet mount examination. You take a sample of the discharge, put it on a slide with some saline, and look for the motion.
Ugh. Okay, but at least this one is treatable. We have a specific poison for this parasite.
Metronidazole or tinidazole. These are
Right.
antibiotics that specifically target protozoa and anaerobic bacteria.
But there is a massive warning with these drugs, a warning that is bolded in every medical text I've ever seen, the alcohol warning.
It is absolute. Patients must avoid alcohol during therapy and for 1 to 2 days after finishing the pills.
Why? Does it stop the drug from working?
No, it causes a disulfiram-like effect. Disulfiram is a drug we give to alcoholics to make them afraid of drinking. It blocks the enzyme that breaks down alcohol.
So the alcohol turns into poison in your blood.
Acetaldehyde builds up instantly. If you drink a glass of wine while on metronidazole, you will get severe nausea, projectile vomiting, flushing, a racing heart. You will feel like you are dying.
Violent illness. Noted. And there's one other crucial part of treating trichomoniasis, since men are usually asymptomatic.
Partner treatment is non-negotiable. If you cure the woman, but not her partner, they have sex again, and he just hands the protozoa right back to her.
It's called ping-ponging the infection.
You have to clear the whole system.
Correct.
Yeah.
We're coming down to the final segment here, looking at the other players. HPV is a big one that the text covers.
Human papillomavirus. It's actually a huge family of viruses, but the text focuses on the ones that cause genital warts condylomata acuminata.
And the treatment there seems a bit more physical. We aren't just taking a pill.
No. Since it's a virus causing a physical growth of tumor, essentially the treatment is often removal, ablation,
Burn them off.
or freeze them. Cryotherapy with liquid nitrogen, or we apply chemicals like pothophyllin resin or acid to burn them chemically, or in severe cases, surgical removal.
That sounds pleasant, but there is good news here regarding prevention. The vaccines.
This is the biggest game changer in sexual health in the last 20 years. The text details Gardasil and Cervarix.
Gardasil is the quadrivalent one, right?
Yet,
Meaning it hits 4 targets.
correct. It targets HPV types 6, 11, 16, and 18. Now, you have to understand the difference. Types 6 and 11 cause 90% of genital warts. They are annoying, but not deadly.
And 16 and 18.
Those are the killers. They're high-risk types. They integrate into the DNA and cause cellular mutations that lead to cervical cancer, anal cancer, and throat cancer.
So the vaccine prevents the warts and the cancer.
Exactly. Cervarix, the other one mentioned, is bivalent. It only targets 16 and 18, so it's purely a cancer prevention tool. It won't stop the warts.
And the target group.
Ideally, before sexual debut. The text lists girls and women, 9 to 26, and also males, 9 to 26. The goal is to induce immunity before they ever encounter the virus.
Before we wrap up, there are a few minor ones mentioned in the tables that I feel we should just acknowledge. Chancroid.
Haemophilus ducreyi. It's a bacteria. The key distinction here, remember, the syphilis chancre is painless. Chancroid causes a painful ulcer. If it hurts, it might be chancroid.
And lymphogranuloma venereum.
That's actually a specific aggressive strain of chlamydia. It attacks the lymphatic system. It requires a much longer course of doxycycline, 21 days instead of just a week.
And finally, the creepy crawlies. The text lists ectoparasites.
Scabies and pubic lice, or crabs. They are classified under STDs here because sexual contact is a primary mode of transmission, skin to skin.
Scabies are the ones that burrow, right?
Yes, the female mite burrows into the stratum corneum of the skin to lay eggs. It causes intense itching.
Okay, I'm itching just thinking about it. Let's take a breath. We have covered a lot of ground. From swimming protozoa to stealthy chlamydia to the brain-eating syphilis spirochete. As we synthesize all this, what is the big picture here?
For me, the synthesis lies in the diversity of these organisms. We aren't fighting one enemy. We are fighting bacteria, viruses, parasites, and protozoa. And they all require different strategies.
And the sneaky factor, that seems to be the universal strategy.
It is. Whether it's the asymptomatic carriage in chlamydia and gonorrhea, or the latency in syphilis and herpes, these pathogens have evolved to fly under the radar. They rely on our ignorance.
They rely on us assuming, I feel fine, so I am fine.
Exactly.
Which brings us to the takeaway. You cannot rely on how you feel.
You absolutely cannot. Symptoms are unreliable. Diagnosis requires specific tools, cultures, DNA probes, wet mounts. You need data, not just intuition.
And the treatment is incredibly specific. You can't just take an antibiotic.
Right. Penicillin works for syphilis but does nothing for herpes. Metronidazole kills trichomonas but won't touch chlamydia. You need the right key for the lock. Precision matters.
I want to leave the listener with a thought that struck me while reading this. We tend to think of diseases as these failures of the body. But when you look at syphilis, it can hide for 30 years before it strikes the brain. Herpes creates a permanent home in your nerves and just waits. Chlamydia spreads by being so quiet you don't even know it's there.
They are masters of survival. They are biologically brilliant in a terrifying way.
They really are. And our only defense isn't waiting until we hurt. It's active detection. We have to be smarter than the bugs.
That is the only way to win this particular battle. Get tested, know what you're dealing with.
Thanks for diving deep with us today. It wasn't the most comfortable topic, especially the swimming pear-shaped parasites, but hopefully you are walking away armed with some serious knowledge.
Knowledge is the best prophylactic.
Ha! Well said. We'll see you on the next deep dive.